Hello, so good morning and good afternoon for all of you. The IFMRS webinar is the first one of a large series dedicated to rare bone disease. IFMRS is happy to provide this first webinar about the new XLH International Guidelines with the title of Sharing Patients and Experts Perspective. And this webinar is supported by Kyowa Kirin. Okay. So for this webinar, we are very happy to welcome the experts of the XLH, and we will have four outstanding talks from Thomas Carpenter, Tenna, Toft, Sylvester, also Leanne and Suzanne de Beur. Just few words about IFMRS, which support is to support the excellence in the fields of the MSK science and to improve the prevention and treatment of all the musculoskeletal conditions and in particular the rare bone diseases. The point is that IFMRS has the originality to be global and to apply to the full spectrum of MSK. IFMRS is an international federation. That means that there is more than 30 partners worldwide that join the IFMRS in order to improve also the networking about MSK. And here you have also the aims and focus area for the next years. The MSK is for us an international priority, and it's a very good way to improve the collaboration and to improve the networking about experts and patient organization. I just would like to focus also of one of the highlights of IFMRS with the IFMRS portal. It's a genomic data mining platform that is extremely useful to learn more about the gene and the disease. So feel free to use it. There is a lot of very nice information in these platforms. Finally, we will be very happy if you could sign up for the IFMRS newsletter and to follow up on the social media. So this webinar will start with the talks, and please do not forget to ask the questions in the Q&A part, and we will have all the questions asked at the end of the four talks. So I'm very happy now to welcome Professor Thomas Carpenter, who is a professor of pediatrics at Yale University, and he will talk about the reflection of the evolution of XLH guidelines and the journey so far. Thank you very much for joining us. The floor is yours now. Yeah. Oh, is muted. So maybe we can ask Thomas.
There, I think that's now.
Yeah, so this is perfect now. Thank you very much.
And sharing the screen.
Yeah. So
first, I think I just want to make sure that that's visible to all. I want to thank the organizers and IFMRS for the privilege of participating in this exciting program, and want to give you a little bit of the background of how far we've come with guidelines and the sort of history of how we've made the decisions that guidelines try to help us with today.
Sorry, Tom.
Yes?
We can't see your screen.
Oh, you can't?
No.
Oh, that's weird. When I went to presenter mode, it went off. Let's try again.
it's not present or it doesn't matter, but we need to see them. So just to say also the audience that the questions could be put in the Q&A part of the
Can you see now?
Yeah, this is good. Yeah.
Let me just make that bigger, because if I can't get to the presenter, it's going to make things a little small. Okay.
Yeah. So I think it's fine.
Okay. So again, thank you for this opportunity, and welcome to the audience. Now, if I can figure out in this slide, this method, how I change, there we go. Disclosures are shown here. I will attempt in these few minutes to briefly review XLH. I'm sure you all know it well. It is an important diagnosis to make correctly because of the subsequent treatment decisions. I'm going to spend some time on giving you the history of therapeutics in XLH and how we basically learned from our predecessors the guidelines we use to treat the disorder, and provide some clarity to the need for standards and guidelines, particularly in this landscape of newer treatments that have emerged and that are on the path. So we know this disorder is the most common heritable cause of rickets. It's due to renal phosphate wasting. In children, we see rickets, osteomalacia if we were to biopsy the patients. What brings them to attention is the skeletal deformity and short stature. We notice in these patients dental problems, particularly dental abscesses. Early in life, we can see craniosynostosis. The biochemical hallmarks are low blood phosphates, decreased renal phosphate clearance, and low circulating 125 vitamin D levels. I highlight in here the rickets and skeletal deformity because that has really driven as targets why we have treated the disorder and how we try to come up with decisions about how best to treat the disorder. We know this disorder is due to mutations in FEX, which we still don't understand too much about, but it is mediated by the circulating FGF23. And with the attention of this disorder to longer term in life, we've now recognized that there are severe long-term complications such as enthesopathy, arthritis, frequent hyperparathyroidism, spinal stenosis, myopathy, and in the days of, as you will see me relate to later, quite a high incidence of renal disease in the settings of excess therapy in the past. So all of these issues, in addition to newer therapies emerging, call for a standardized and global approach to the disorder for both children and adults. Stuck. So to simplify the physiology, we see here the kidney in the normal situation on the left, managing conservation of phosphorus is shown by the arrow leading downward, such that there's adequate ambient phosphorus to be available to the skeleton to promote mineralization. And in XLH, this loss of phosphorus in the urine and quite extensive and dramatic urinary phosphate throughput through the kidney results in limited availability of the phosphate for the skeleton. One gets rickets, osteomalacia, and the secondary defect, also promoted by the excess FGF23, is the inhibition of 1-alpha hydroxylase and promotion of excess catabolism of 25D so that the circulating 125D levels are low. So how did we get to where we are? In a brilliant paper from the 1930s, Fuller-Eyebright and his colleagues characterized this unusual form of rickets, and he entitled it vitamin D resistant rickets because of the failure of vitamin D to cure the disease. in the usual doses that you would treat most types of rickets with. This paper characterizes so many of the features we know about XLH, including the hypophosphatemia due to excess urinary loss, yet with normocalcemia. And in fact, before you could even measure parathyroid hormone, this kid is admitted for months to the Mass General Hospital, and they end up deciding to do a parathyroidectomy, and he has parathyroid hyperplasia. So many of the features called out in the 1930s. But the focus was on the vitamin D resistance. And because that was viewed as the central issue, the approach became to use extremely high doses of vitamin D. And as summarized in what I thought was the best guidelines when I was a fellow, the chapter in the Connie Anist and Howard Rasmussen chapter in the classic textbook, The Metabolic Basis of Inherited Disease, they pointed out that the high-dose vitamin D never increased the serum phosphorus, had perhaps some improvement in rickets with perhaps fewer surgeries performed, no change in growth, and such frequent vitamin D intoxication that it was not an acceptable therapy. So in the late 1950s and early 60s, focus began to shift from the vitamin D resistance to the phosphate wasting as a cardinal player in the pathophysiology of the disease, and treatment with phosphate emerged. And that had better effects than the vitamin D, but it resulted in a striking hyperparathyroidism, so that investigators then began to mix the two therapies, treating phosphorus with vitamin D. And this was better than anything that had been done before, but it still required fairly high doses of vitamin D, and the risk of vitamin D intoxication continued. And then around 1980, studies were published that showed the superiority of phosphorus plus activated vitamin D metabolites, particularly calcitriol in the studies, as superior to these earlier approaches. And what we would call guidelines today were really the paragraphs on treatment in reviews and textbooks that focused on those studies that described the first treatments with calcitriol and phosphate. There was sort of a parallel literature going on too about how to manage these patients surgically in the orthopedic literature. It really didn't get to medical approaches in those reports. But the real pioneers of this approach were the classic Francis Glorio article in the New England Journal in 1980, and then Mark Dresner and his group at Duke had a similar publication in the same year, and Howard Rasmussen and Connie Anist also did this with alpha calcidol around the same time, with a publication the next year, all of which showed superiority to the older therapies. So with this new paradigm, people started treating XLH with calcitriol and phosphate, and new complications emerged. And the phosphorus still generated hyperparathyroidism, and the parathyroidism could make the phosphate wasting worse, and in fact could also make you hypercalcemic if severe enough. As we learned about FGF23, we learned that phosphorus can increase the FGF23, as can calcitriol, and you can begin to work against yourself if you overtreat with these medications, both further impairing 1-alpha hydroxylase activity and phosphate wasting. So it was in the late 80s that we were accumulating experience with these medications, and I'm sure others as well, and referring doctors, and many people started to call us, "Doctor, what do I do now that I've started using these, and I need some help and guidelines into what to do?" In fact, we started getting so many of these calls that we discussed this at a NIH conference with others in 2008, which generally was considered a widespread need for some readily accessible guidelines to actually quote what came out of the Advances in Rare Bone Diseases conference back then. And some of us on the call today and others contributed to trying to get this into some form where doctors that took care of bone diseases would see it. And that resulted in the 2011 publication of A Clinician's Guide to X-Linked Hypophosphatemia, which was our first attempt at formalizing some kind of brief guidelines that were accessible. And Suzanne may remember this. We had a devil of a time getting the editors at JPMR to entertain publishing something of this nature. And I don't do this much, but I was looking at what people have paid attention to in my career, and by far and above, this has been the most quoted paper I've ever been on. So I do think that this had some impact. And now, there. And then came burosumab shortly after that publication, and the whole landscape changes. So this now with a new treatment, running into new problems, new treatment strategies, all of this has created the need for new guidelines in a new therapeutic area. So over the past decade, there have been particularly with the emergence of burosumab, a whole bunch of guidelines that have been published. They're accessible. They're very good. They tend to be regional and expert opinion related. You can see I've listed some from Britain, Belgium, Spain, Asia Pacific, seven European countries, and some that have actually appeared recently since the effort by Aliyah Khan and her fellow that we'll discuss today. So this was a Herculean task of trying to make guidelines as rigorous as possible, to make it a global consensus, to include people from disciplines across the caregiving spectrum that are involved in the care of children with XLH, involving people with with really the expertise in evidence-based medicine, allowing us to do this in the so-called graded methodology, which I'll discuss momentarily, and put into perspective the differences of making the diagnosis, of monitoring children, as well as treatment. And these were parallel efforts for both the childhood population and the adults. So once again, kudos to Aliyah Khan and her fellow Dalal Ali for spearheading this incredible effort. My arrow is not always working. There we go. Again, just describing that this included many, many specialists, including patient advocates and patient partners of the disease. So a very broad approach to putting these guidelines together. And Dr. Guyette from Ontario, who was really the founder of evidence-based medicine, keeping us on track in allowing us to not be too outspoken from simply anecdotal experience on many Saturday mornings over the 2 years that this effort took. So Doctors Khan and Ali assembled a group of people and divided this up into different committees. As you can see here, they served as the overall chair and co-chair. There was a methodology committee, and the important questions each were structured, and various members were assigned to these different committees. Did the evidence-based review looked at the data wrote the first drafts, and then what they brought to the table on those conference calls was a draft that the whole group would discuss. So in summary, what this effort did was define the appropriate clinical questions, provided systematic structured reviews with formal literature searches. These were all assessed for the certainty of the evidence and limiting the bias of those publications. And then these graded recommendations based on assessing and development and evaluation of the literature were made. And in some cases, the amount of data available or the number of studies just weren't there. So the process also allowed for what were called non-graded recommendations. And this was informed by a narrative review of the literature. In some cases, some combination of graded and non-graded recommendations were made. Some of these were also informed by surveys of practitioners taken to complement the literature review. Oh, come on. So we ended up, after this process, with systematic reviews aimed at comparing therapies, both in the childhood and the adult populations, a very detailed methodology description, a table of findings that I believe Suzanne and Leanne will go over for specifically the adult and pediatric work. A recommendation that not only is, yes, you do this, but how good was the recommendation? How strongly can we recommend it based on the quality of the evidence? And this whole process allows for further updating as new information comes through in the future. So a very comprehensive approach. So this is just a diagram of the way the comparisons were set up and what outcomes were important to look at in the way the structuring of the comparisons were done. The children are shown on the left, the adults on the right, but essentially with some minor differences in the outcomes that are relevant to children and adults. The paradigm is the same. So children were looked at if they were treated with burosumab, if they were treated with the old conventional therapy of phosphate salts and active vitamin D. The comparisons were set up to see what was available to tell us about how does burosumab stand up to the old conventional therapy. Secondly, how does burosumab stand up to no treatment? And thirdly, how does the old conventional therapy stand up to no treatment? And this was approached in both groups with patient-important outcomes that are overlapping considerably between the children and adults, and what we might call markers or surrogate outcomes, such as the laboratory tests and radiographic findings across the two. So this is a draft of what the range of recommendations were. If there was sufficient evidence to make a so-called graded recommendations, these could be strong, which represented the panel being entirely confident that the intervention outweighed any undesirable effects, and the language that then gets translated into the guidelines in this setting is "we recommend." And then in the context of conditional recommendations, recommendations that might be applied only in certain circumstances, or the data's kind of weak, the language changes to "we suggest." And then for those in which you really can't do a systematic review, there really can't be a so-called graded recommendation, and the language for those thoughts are that the panel proposes. And this is a graphic that got applied to both the children and adults. In this particular case, you can see that for initial assessments, this was a "we suggest" recommendation, and I believe Leanne will go over this in in more detail in her talk. So in addition to all the work to give validation to the global nature of this, international societies signed on with endorsements, and many of these were applied to both the pediatric and the adult guidelines. And at that point, I will stop and want to acknowledge the enormous dedication and effort of all the investigators, clinicians, the methodologists, and the patients and advocates that made this entire project possible. And I'll stop there.
Thank you. Thank you very much. So this is a very good illustration about the fact that it will take time from the clinical recognition of the disease and the pathophysiology, and then to the treatment. Thank you so much. So now it's time to have the opinion of the patients. So I'm happy to introduce Tenna Toft Sylvester from the International XLH Alliance. Tenna will provide the opinion of the patients and the perspective on the new guidelines that have been published recently. So, Tenna, thank you very much for being here as well.
Yeah, thank you very much. And thank you very much for inviting me. I believe Frederic will share my slides very shortly. Here they are. So, next slide, please. So my name is Tenna Toft Sylvester, as Martine already said. I'm the co-founder and the co-chair of the International XLH Alliance since 2019. I'm also the president of the Danish XLH group, and I've been that since 2018, where I also helped co-found that. Just to share also that we also have HPP patients actually in our XLH group. I'm also a part of a European reference network called ERN Bond, and I'm a member of their steering committee, and also a part of what is called a Europe Patient Advisory Board. That is a European registries for rare endocrine and bone disorders. And in my private life, I like to say, I work as as an IT senior consultant. I'm a patient with XLH myself. I was diagnosed at 18 months, and then I'm a mother of 2 girls, twins, who are now 9 years old, and I actually have my own little case study at home, I like to say as well. Next slide, please. And these are my disclosures. Next slide. And today I just want to speak a little bit about, obviously, what the International XLH Alliance is. I will share a little bit about my own journey and my daughter's journey, and then also go through some of the insights that we've learned over the years working with the Alliance from the communities. I want to talk a little bit about the priorities that the community has, and obviously talk about guidelines and why they matter so much to us. And finally, have kind of like reflections, perspectives on how the International XLH Alliance and the XLH patient groups can contribute to achieve better care. And next slide. So a little bit about the International XLH Alliance, for those who do not know the Alliance. It was formed in 2017, I believe, and we're now an alliance of 33 countries around the world. And basically what we are an umbrella organization for XLH patient groups. So we don't have patients as our members per se, but we have their patient groups as members of the Alliance. And what we basically work for is to help support each other's work. We share ideas, we have a global campaign, and really try to unite a global voice for the XLH community. And next slide, please. And actually this is some of the campaigns that we've done in the past, where we, for example, had Access Your Best Care, which was a campaign where we went through some of the guidelines at that point and created some recommendations on our own But the idea here was actually to disseminate the guideline in pictures and in languages that was easily translatable. We translated into different languages so that our patient groups could share this information as well. Yeah, that's all I want to say about it. So we do some work on trying to make sure that our patient communities and our patient groups understand and know the different guidelines that are out there. And next slide, please. And just to let you know a little bit about my journey, so I found it always interesting to hear Thomas Carpenter go through the history of treatments and XLH. So I'm a spontaneous case. I was born in 1981. I can't remember how old that makes me now, but I had conventional treatment and I still do that. But in I believe in 1999 or so, I was actually told that I didn't need any treatment anymore because now I was fully grown and I was kind of written out of the healthcare system. So this was, I guess 1999 in Denmark. And maybe 6 months later, I was called again by a doctor who said, well, we just realized that we actually have to continue medication regarding your bone health. So I got back into treatment again after probably 6 months break at that point. And again, the next kind of date for me is in 2016, where I gave birth to my twin daughters. And this is also where I actually met my first other XLH patient, my daughter. And our first encounter with care and with healthcare system in Denmark was actually a bit of a struggle. I knew obviously that I had XLH, and I really wanted them to try to test my children to see if they had inherited from me. And this was actually very difficult to get them to understand that this was something that I needed them to do. So I just stayed at the hospital until they did. So I stayed there for 10 days. And then finally they did some testing and found out that one of the girls had inherited XLH. And I live in Copenhagen, and we actually we're connected to one of the best hospitals in Denmark. That's at least what I would think, and I don't mean to criticize them too much, but what the next meeting I had with the healthcare system was that they gave me an appointment 6 months after my daughter was born to start treatment. And for me, that was not acceptable. So I really started advocating and figuring out, well, who would then treat her immediately. And that's where I moved a hospital and then moved to another city. And actually, my daughter started with Signe Bech-Nielsen at that point. So my daughter's treatment started after 1 month of birth. So this was my first and her first part of the XLH journey to get that type of treatment. And also just to share the information, you may not know, but in Denmark, there is the new treatment, Beur is available, and it has been since 2021. But it's available for children with a certain set of criteria. So this means it's not a standard treatment for children, but you have to meet certain criteria. And my daughter does meet those criteria and is on Beur. I think the ongoing fight in my own journey is also realizing probably in my mid-30s that XLH was actually a progressive disease. I didn't really have a full understanding of what XLH was, and I didn't really realize this until it started becoming, more limiting and more painful, and had a lot of more impact on my quality of life. And that realization, and together with the birth of my daughter, is also what kind of sparked me to start advocating. So I think one of the ongoing fights for me is definitely to make sure that my daughter does not experience the same outcome as me. That is my main focus, is to make sure that she's able to access the best care. So some of the reflections that I have on our journey and on our treatment is obviously because in Denmark it's the new treatment is approved for children and not for adults. I have questions about, well, will my daughter be able to continue her current treatment? What will happen to her bone health, having to change treatment plan? And obviously, as I also have some general questions about, well, will she have the same outcome as me? You know, stuff like stiffness, will that actually be helped by Burosumab or not? So I think overall, also, one of the biggest struggles that I face or have faced is probably knowing that there is a better care possibility, but it's not available, and not, even though it's recommended for me, it's not something that I can actually access. And coming from Denmark and speaking to a lot of different countries, I think people are always very surprised that this is the case. But it is the case, and we do see that also throughout many countries. And finally, I think also key is just to have really good communication with your doctor and to make sure that they hear what we're saying in these meetings that we have and be taken seriously. And although they cannot help whatever the possibilities of the treatment plans are, it's always good to be able to have that discussion and talk about, well, what is the decisions around my treatment plan? Because again, that helps us cope both mentally as well. And next slide, please. So this was a little bit about my kind of journey so far with treatment and care in XLH. But I really want to turn to give you some more insights from our community. And what probably will not surprise this audience is that the struggle is pretty much the same in many countries. So what I have experienced with a diagnostic challenge, which was actually not that bad if you look at other countries, there's many places where we still see diagnostics challenges. We see problems with access to treatment. We have this great hope, and I think for a lot of the countries that I've talked to about, it's obviously about, well, what does this new treatment mean? So even though there's this great hope, there's still so many huge differences in what the care looks like in each of these countries. So what we see is there is obviously children, adults, where we see children it's getting better. That's definitely what we see. But there's still a lack of knowledge. There's still a lack of multidisciplinary teams, even though that recommendation has been around for many, many years. We see also huge differences nationally. We see huge differences in Europe, for example, and at local levels when it comes to both what quality of care patients get, and again, going back to what availability there is of even multidisciplinary teams or other types of care or treatment. Many places there may not be an expert in XLH in your country. We see challenges of actually being referred to the expert. So there might be an expert, but the hospital where you're located or close to you, they do not want to refer you maybe to that expert. Obviously, there is economic priorities. I mean, Denmark is, I guess, considered a rather rich country, and still there's economic priorities. And also another thing is consultation time. I think this is a general capacity or resource capacity challenge that some patients maybe see their doctor 30 minutes a year. And that also, really means that those 30 minutes really have to be good to kind of cope and fully address all the issues that they face. So I think we still have many challenges ahead, but obviously having great guidelines is helpful and is something that can help us really improve care and what we can achieve with what we have. And next slide, please. So in the XLH community, we have some different priorities on what we would like to work on. And obviously, one of the things that we continue to focus on is access to care. So access to diagnosis, treatment, access to specialists, and some of the things that I went through in previous slides. We also have a concern about transition, and here I mean not only transition from from child to adult care, but also the transition in care, for example, in treatment plan, as I was saying before, what happens if we change the treatment from beruzumab to conventional treatment, what happens long term if that happens. So I think there's a lot of focus that we would like to have on that particular matter. And again, adult care, I think it goes again with what availability there are for adult care. We need greater attention to things like pregnancy. From my personal story, I know that pregnancy definitely led to a lot of progression in XLH for me. There's also many questions about what menopause and how do we, are there specific needs that needs to be attended to in geriatrics? And obviously, as patient communities, we always want to create some, or to make some of these decisions together, co-create. We would love to keep on focusing on how we can share this decision-making process, and then obviously we still see the gap of knowledge. So focus is also how we can empower and educate people who do not have experts in their countries, so we can provide the optimal care and get really full value of what is available in that country. Because there is also a lot you can do from just following the guidelines on conventional care, for example. And yes, women's health, hormonal influence, and not least mental health is also something that is a priority. And I'm sure there's many more, but here are some of the top priorities at least. And next slide. Yes, so I wanted to just begin by saying that it's really great to have all these guidelines. They're really good, I think. There's some good recommendations and suggestions and etc. And they really matter a lot to the community to have these guidelines. We use them a lot. We share them. We ask patients to bring them to the doctors if they, for example, are not able to get a referral to an expert. So it's something that is that really means a lot to the patient community. And as I think Thomas already went through, we enjoy being involved in the process of developing guidelines. We're always happy to help, and then also to kind of give our input on which areas need to be further explored. It's also key for us to kind of really find a way of how we can then help get the most out of these guidelines. We think we have a great opportunity of the platform that we have to kind of make sure that that we get these disseminated and we help facilitate these guidelines. So we have to make sure that, for example, the members of the Alliance also really understand and know what the guidelines are, so they can help their communities. And again, patient groups in general also play a vital role when it comes to their own countries, when we speak to policymakers and decision makers to kind of make decisions on what access or what treatment should be available in the countries. So again, guidelines, they matter so much to us, and we appreciate these guidelines a lot. We think they're really great. And again, we just want to make sure that we actually make they go out there and they go out to the experts and the doctors, and we make sure that people understand the guidelines. And again, going back to the struggle I had before with that, sometimes it can also be a little bit frustrating if you know that there are some guidelines recommended a treatment, for example, and it's not available. So obviously that's also a thing to consider with guidelines. And next slide. Yes, and here are some reflections on how we as a full community can contribute to improve care. And as I mentioned before, I think one of the things that we want to focus on is really try to figure out how we best inform and educate, even within the XLH patient groups advocates, to make sure that people fully understand what the different guidelines are, again, to help the process in their countries. So the Alliance and our members, we can definitely help with disseminating guidelines across our communities. We can help communicate them in maybe layman versions or do materials like I showed you in the beginning, where we do some drawings or some different recommendations for people to really both translate into their own languages and make it easy accessible to share at social media and etc. We would obviously always love to help with prioritizing future research and get the input from our communities on where the concerns are. And again, engage actively where we can in research initiatives. And finally, yeah, we just want to partner with you again in updating the guidelines. And I was happy to hear Thomas mentioning that it's actually created in a way that it's easy to kind of add new research into these guidelines and update them. So I think that's a huge bonus. Yeah, so these were some reflections from the XLH Alliance. And again, thank you very much for inviting me. And thank you so much.
Thank you very much, Tenna, for providing your insight, because your voice matters a lot for us. So now we are also happy to welcome Professor Leanne Walls. She's a professor of pediatrics at the University of Ottawa in Canada, and she will provide insight about the international guidelines in the pediatric point of view. Thank you very much. So we have, I think, around 15 minutes, if you could help. So it will be good to allow the questions. Thank you.
Well, slides are advancing on their own here. Thank you so much for the opportunity to present today. It's really a wonderful chance to talk about what the XLH guidelines mean for the pediatrician. I appreciate, Tom, how you've so nicely set us up with respect to the history of how we got to where we are today. And thank you, Tenna, for that wonderful narrative about your journey, your daughter's journey, and the community's reflections on expectations as we go forward. So these are my disclosures with funds to my institution, and the pediatric guidelines have been embodied in this publication and tackle diagnosis, the initial evaluation, the management of XLH, and ongoing monitoring for children. What I love about guidelines, and Tenna has already alluded to this, is they do provide a benchmark against which clinicians can say, am I meeting the guidelines? What do I need to do to progress in my clinic so that I'm meeting the guidelines? We can take this to our institutions and say, we're not meeting guidelines in this realm. What can we do as an institution to get there? Guidelines provide an opportunity for critique and adjudication of those guidelines, and research together with that critique drives the field forward to future revisions that constantly calibrate the care. So guidelines, as Tenna has so nicely said, indeed are so very, very important. As Tom mentioned, the guidelines have been developed with experts in XLH, guideline development experts, as well as patient partners from Canada, the US, Europe, Asia, and Latin America. Tom also alluded to this, but to really chisel down on the way in which this has impacted the pediatric guidelines, there was sufficient evidence with respect to treatment to undertake systematic reviews and evaluate the information according to the grade adjudication system. So that was very nice to see. With respect to diagnosis and monitoring, however, there wasn't sufficient published evidence to do a graded approach per se. And so it was expertise that drove the recommendations here, including a narrative review for diagnosis and clinical practice survey-informed monitoring. Remember that when we say recommend, that reflects strong recommendations. When we say we suggest, that reflects weak or conditional recommendations. And when we say the panel proposes, this is non-graded recommendations that have been derived from this clinical practice survey and from the narrative review. So I'll talk about the key messages now, which reflect diagnosis, the initial assessment, management, and monitoring. With respect to the diagnosis of XLH, We want to establish that there's chronic hypophosphatemia due to renal phosphate wasting in the absence of any other explanation, supported by X-linked dominant inheritance or a pathogenic FEX variant. In the guidelines, there's this beautiful algorithm that I'm not going to go into in too much detail, but suffice to say, it's been divided into whether you have FGF23 available to you or not. Whether you have that measurement available to you, you can arrive at a diagnosis of FGF23 mediated hypophosphatemia. And this is the typical biochemistry that would support FGF23 mediated hypophosphatemia. The serum phosphate is low, the calcium is typically normal, the PTH is normal or slightly elevated, the vitamin D level normal or low, 125 is inappropriately normal or low. FGF23, if you have it, is inappropriately normal or high. Urine calcium creatinine is typically normal or low, and TMP-GFR will be low, along with a high alkaline phosphatase, the biochemical signature of rickets, and osteomalacia. And then once you've narrowed down to an FGF23 dependent condition, there's a differential diagnosis there that you can work through. And I just want to make the case that although we're focused on XLH today, remember, if you have unusual skin features in a child not growing well or with bowing deformity or low phosphate, or they have dysplastic bone that you can see on X-ray, remember that that bone may be overproducing FGF23. And then you'll take your diagnostic steps to genetic testing, candidate gene panel, for example, looking for a variant in FEX. And at the same time, recognize that some patients with XLH, we can't find a FEX variant through candidate gene testing. You may need to move to innovative approaches like RNA sequencing and looking for deep intronic variants. And this has come out in the published literature. The initial assessment recommendations, the panel suggests taking a careful history, including the family history, to identify others in the family who may be affected, to assess pain and absences, to look carefully at the child's anthropometry, including blood pressure, to do the laboratory investigations I mentioned, to do the genetic testing, as I stated, and to do imaging to look for rickets, lower limb deformity, and to establish a baseline renal ultrasound phenotype. We did have sufficient published evidence to make graded recommendations with respect to treatment for children who are 12 months of age or older. The panel recommends burosumab over conventional therapy. For children 6 to 12 months of age, the panel suggests burosumab over conventional therapy. In terms of the nuances of treatment, the panel proposes, reading left to right, that we start medical therapy upon confirmation of XLH diagnosis and a low phosphate. And that speaks to what Tenna mentioned, that we do need to be seeing these babies early if there's a family history, or as soon as we see that there's potential for phenotypic features associated with the diagnosis, so we can institute early treatment. The goals of treatment are to improve the clinical, radiographic, and biochemical signs of the condition. When burosumab is not available, then we treat with active vitamin D, and usually along with phosphate salts. For some reason, if phosphate salts are not available, it is acceptable to use calcitriol, active vitamin D alone, but preferably this is in combination. Phosphate monotherapy is contraindicated. Conventional therapy is advised over no treatment, and on conventional therapy, we need to be avoiding fasting serum phosphate levels that are excessive. Specifically talking about the burosumab paradigm, the panel proposes that we need to be adhering to recommended starting doses, which are in the guidelines. We need to avoid hyperphosphatemia at any time in the dosing cycle. We need to adjust doses so that the peak is in the normal range, but does not exceed the mid-normal range, and the trough is slightly below the lower limit of normal or just slightly above. Burosumab is contraindicated in CKD and in acute kidney injury, and caution is to be exercised if the eGFR is 30 to 60 ml per minute or lower. The panel proposes that the routine use of recombinant human growth hormone is not advised due to insufficient evidence for benefit in randomized trials, early involvement of orthopedics, and tertiary hyperparathyroidism can occur with treatment, in which case we expect multi-gland hyperplasia. We should consider calcimimetics to try to rectify that situation. And if the hypercalcemia is uncontrolled, then subtotal parathyroidectomy would be indicated. Now, these are the monitoring recommendations that have been graded because of the level of evidence available. I'm not going to go through them in intimate detail, but suffice to say that you can see when you look at the monitoring guidelines that we do want to be seeing children every 3 to 6 months with XLH in order to look at their anthropometry, to assess their deformities, to be evaluating their biochemistry. 25-hydroxyvitamin D is recommended annually because that can so often co-occur. We recommend looking at renal health annually or less frequently, depending on the nephrocalcinosis status. We recommend looking for signs of rickets on x-rays periodically, and to do targeted x-ray to assess for fractures, pseudofractures, lower limb deformity, and the presence of localized pain. And then we need to be asking about dental infections and maxillofacial cellulitis and doing that every 3 to 6 months. And children should be engaged with a dentist at least by a year of age and then be followed by a dentist every 6 to 12 months. For children who are 6 years of age and older, we do recommend a more focused dental exam with imaging in order to screen for specific dental complications of XLH, including enlargement of the pulp chambers, prominent pulp horns, and pulp necrosis. Even more about dental care, because this is so important, is to say that we need to be optimizing medical care before children go for orthodontic care, use the technology available to do careful evaluations, which may even include cone beam CTs. And we recommend that dentists exert anticipatory preventive kind of measures such as sealing pits and fissures on temporary and permanent teeth in order to try to avoid dental abscesses, which can be so problematic for some patients. Hypertension can be a feature of this condition. We recommend that in the course of doing routine blood pressures at clinic, if they're exceeding the 95th percentile for age and height on repeated measures, then the child should go for 24-hour ambulatory blood pressure monitoring or serial home blood pressure measurements with appropriate referral to a collaborating nephrologist. Hearing can be affected in childhood. I think at one time we thought perhaps it was unique to adults, but no, this can start in childhood. So hearing tests are advised periodically. And remember that Chiari-1 malformation and syringomyelia can be comorbid. So we need to be doing neurological examinations, including fundoscopy in the presence of concerning neurological signs with appropriate imaging and referrals depending on those findings. And we would take those neurological assessments during the course of our routine 3 to 6 month evaluations. The guidelines remind us the importance of attention to transition from childhood to adult care and to engage physiotherapists as needed in order to support the children on their journey when they have pain and functional limitations arising from the pain. I love that the guidelines enumerate the research agenda, and Tenna, you have also highlighted for us today what we need to be thinking about, but on the minds of the pediatrician is whether burosumab in childhood can improve comorbidities later in life. If we start less than a year or even less than 6 months, if we ever get to that point, we don't have the evidence to go below 6 months with burosumab just at the moment, can that portend a more favorable prognosis later in life. And we have much to learn about hearing and dental issues and enthesopathy and neurosurgical consequences of this condition as well. What I appreciate about the guidelines as a clinician is that they provide a lovely diagnostic algorithm and a list of known genes in chronic phosphate wasting. There is now sufficient evidence to recommend burosumab over conventional therapy. They underscore the need for multi-expertise, multi-D care. They highlight for us where there's insufficient evidence and where we need to work harder to gather information to provide clarity. They emphasize the importance of that delicate transition from pediatric to adult care. They remind us to think about the kidneys, and they discuss the importance of auditory, dental, renal, vascular, and neurosurgical surveillance. And then as a researcher, what I love about these guidelines is they do, like Tenna did, enumerate for us where the unmet needs lie, and that provide us with a sight line on the future in terms of our lines of inquiry. They also remind us, just as Tenna said, that expertise and resources and tools and therapies are not universally available. And I think as a global community, we're behooved to work together in order to ensure that every child globally has access to what they need to thrive during the pediatric years. And with that, I'll thank you for your attention and just say that as a McMaster graduate of their medical school, I'm so thrilled that this is where evidence-based medicine had its birthplace and has continued to be a pioneer in guidelines such as this. And thank you to Dr. Kahn for spearheading these guidelines. Thank you very much.
Thank you so much, Leanne, for this very clear and very straight overview of this delicate and complicated topic. In the end, I think it brought a very nice overview of the new guidelines. It's now my pleasure to lead over to Professor Suzanne de Beur, who is Professor of Endocrinology, Chief of Division of Endocrinology and Metabolism in the University of Virginia. So Suzanne, stage is yours. Thank you.
Thank you very much. Well, I realize that my time is running short, so I will been so grateful for the great setup by Dr. Carpenter, by Tenna, by Leanne. And so some of these slides we will be able to go through relatively quickly. So these are my disclosures. And I'm going to focus on the adult guidelines of the International Working Group. And here's the publication that was published in JCNM just earlier this year. And what I love about the guidelines is that I got to confer with this wonderful group of 50 experts in many different areas, including patient representatives, dentists, nephrologists, orthopedists, and really be able to put our heads together to try to come up with the best guidelines that we come with the available evidence. So to quickly remind you, the guidelines assessed these questions about diagnosis and treatment and whom to treat and how to monitor in special populations. And we were able to form graded recommendations from our 4 systematic reviews in children and adults. And then 43 members of the International Working Group filled out a rigorous clinical practice survey, which we derived some of our other graded recommendations, including the monitoring recommendations. And then the non-graded recommendations were where there wasn't sufficient evidence, and we relied on literature reviews and consensus for those non-graded recommendations. So this is just the overview of what the guidelines in adults with XLH sought to address. So to start out with the diagnosis, we start with some non-graded recommendations. So to make the diagnosis in adults, again, as Dr. Ward was saying, we need to demonstrate chronic hypophosphatemia due to renal phosphate wasting with an X-linked inheritance pattern, and ideally in the presence of a variant in the PEX gene. But we know that some individuals, up to 10% of individuals with XLH, won't have a variant in the PEX gene. And some people don't have a family history because they are de novo in their family, like Tenna was. And again, I show this schematic as Dr. Ward did to show you the diagnostic algorithm with FGF23 and without FGF23. So our graded initial assessment was based on our clinical practice survey, in which 80% of the survey participants had to perform this 80% of the time and up to 80% of their patients. So that was the bar that you needed to reach to be able to say that these initial assessments needed to be performed. So we thought that we needed to document a family history of XLH or an X-linked dominant inheritance pattern, fractures and pseudofractures, dental abscesses, and periodontitis. We needed to measure standard height, weight, BMI, and blood pressure, perform a musculoskeletal examination, looking for bony tenderness and range of motion, and also perform genetic testing for hypophosphatemic associated genes, including PEX, to make sure we had the right diagnosis. The biochemistries that Dr. Ward had mentioned are also recommended, as well as a baseline BMD assessment was recommended by 80% of the respondents. And then baseline dental assessment with apical x-rays or orthopantogram to screen for enlarged pulp chambers, pulp necrosis, or periapical bone loss. So our systematic reviews in the adults, when we are talking about graded recommendations for treatment, addressed two separate sets of questions. So we wanted to look at what's the impact of treatment of burosumab versus no treatment, and then what is the impact of treatment with burosumab versus phosphate and active vitamin D on patient-reported outcomes. And then our second systematic review focused on, in adults, what's the impact of treatment with phosphate and active vitamin D versus no treatment on patient-reported outcomes. And again, this is what I also really liked about these guidelines, are that we really focused on the patient-reported outcomes, or the patient-important outcomes, I should say. So for our first systematic review, we looked at 7,000 records and yielded one study that could be included in this systematic review of looking at burosumab versus conventional or no therapy in adults. And this, of course, was a study by Insomnia et al., published in the JBMR, which randomized 134 adults with XLH to either treatment with burosumab or a placebo, and looked at the different outcomes at 24 weeks. So this was had a low risk of bias, and it was a strong study to include. So just briefly, in this study, in individuals treated with burosumab, their serum phosphoruses rose into the normal range. Those treated with placebo remained below the normal range, but when crossed over to burosumab treatment, rose into the normal range. And importantly, one of the most robust outcomes was looking at the fracture and pseudofracture healing. In individuals treated with burosumab, there was 43% of the baseline fractures were healed at 24 weeks and up to 63% at 48 weeks, whereas those that were treated with no therapy, there was very little fracture healing at 24 weeks, 7.7%, but when crossed over to burosumab, had improvement in fracture healing. It was surprising to us that at baseline, about 50% of the individuals that were entered into this trial had fractures or pseudofractures at baseline, and that was and they didn't know it. To further emphasize the effects of burosumab on bone, this was a study performed by Insomnia et al., published in 2019, where they looked at 14 individuals who hadn't been previously treated for the 2 years previous, treated with burosumab, and had paired iliac crust biopsies at time 0 and at 48 weeks. And what you can see here, there was improvement in osteomalacia with decrease in the osteoid volume per bone volume, decrease in the osteoid thickness, decrease in the osteoid surface per bone surface, and decrease in mineralization lag time. You can appreciate in the lower panel, the osteoid, which is denoted by the red-pink substance, is a lot thinner than the osteoid that's present in the upper panel at 48 weeks. Looking at other outcomes based on this study, as far as pain, there was the plain language summary is that burosumab probably improves pain, the pain that is associated with fractures and pseudofractures. And this is moderate certainty of evidence. But improvement of pain based on the brief pain index, the plain language summary is that burosumab probably has little or no impact on that pain based on the data presented in the paper. And then with a high certainty of evidence, the thought is based on the brief fatigue index that burosumab has little or no effect on fatigue. And then looking at adverse events, their thought there is burosumab may have little or no difference in adverse events and may not increase the frequency of treatment-related serious adverse events. Interestingly, with low certainty evidence looking at dental abscesses, burosumab may increase the dental abscesses. It's unclear whether this is progression of the underlying disorder or related to burosumab. So the systematic review strategy for our second PICO question, which was the conventional therapy versus no treatment, there was 2 studies out of 7,043 that we were able to include in our systematic review. And these were Eric Emmel study in 2010 and the study in 2018 by Schanbog. In Dr. Emmel study, this was a small study with 3 individuals on conventional therapy with 5 individuals on control. These were the adult patients, and the mean duration of follow-up was 14 months, and they were on phosphorus and active vitamin D. In the Schanbog study, there was 11 individuals on calcium and phosphorus and calcitriol, and 16 individuals were on no treatment. And there was a follow-up of 6 years. And again, these studies were thought to have a high risk of bias. Basically, in the Emmel study published in 2010, in this very small study with follow-up from 14 to 25 months, conventional treatment was associated with increases in FGF23, as Dr. Carpenter talked about, related to the phosphorus dose. And the potential concern was that conventional therapy might contribute to complications. And the other 6-year prospective cohort study of 27 adults, bone mineral density in the lumbar spine and hip did not differ significantly between those treated with active vitamin D and phosphorus versus those who are untreated. BTH, FGF23, 1,25-hydroxyvitamin D, and P1NP didn't change in either group. The C-telopeptide was increased in the conventional treatment group versus the no treatment group. And there was a trend towards decrease in calcium, phosphorus, and TMP-GFR in the conventional therapy group. So based on these data, there was a graded recommendation for treatment in adults. And with a strong recommendation with moderate certainty, the panel could recommend that burosumab therapy over no therapy was suggested and was recommended in adults with fractures and pseudofractures. In adults without fractures or pseudofractures, the panel suggested, with conditional recommendation low certainty, that burosumab over no therapy be used. And in an equal conditional recommendation of low certainty in adults with fractures or pseudofractures, it was suggested that burosumab therapy be used over conventional therapy. So now we're going to talk a little bit about some of our non-graded recommendations. So in the non-graded recommendations for treatment of adults, first of all, there was a non-graded recommendation that transition to adulthood, metabolic bone disease experts and multidisciplinary teams need to address disease-related comorbidities, and that medical therapy, whether with burosumab or with active vitamin D and phosphorus, be continued for at least several years following epiphyseal closure for optimizing peak bone mass to approximately 20 to 25 years in asymptomatic individuals, and a suggestion to consider benefits and risk of treatment and ability for ongoing monitoring in adulthood. Other non-graded treatment recommendations were initially assessing adults with a skeletal survey to detect pseudofractures, because we found such a large number of people didn't realize they had pseudofractures but did, and this would then move them into the treat with burosumab category. Medical treatment, either with burosumab or active vitamin D and phosphorus, is required if symptoms or biochemical or histological evidence of osteomalacia exist, such as bone pain, weakness, osteomalacic fractures, elevated alk-phos, or osteomalacia on bone biopsy. And medical therapy, either with burosumab or active vitamin D and phosphorus, needs to be optimized prior to any orthopedic procedures or dental implant surgeries. Further non-graded treatment recommendations in adults were about how to treat. So for those on burosumab therapy, just as in children, we recommend adhering to the starting doses and adjusting the doses as in the label, to keep phosphorus in the mid-normal range at peak and just below the normal range or at the low normal range at trough to avoid hyperphosphatemia. Again, furosemide is contraindicated in CKD and used with caution in those with an eGFR between 30 and 60 ml per minute. If furosemide is not available, symptomatic adults need to be offered conventional therapy. And conventional therapy should not be, the target should not be to normalize fasting phosphorus, because you will overtreat and cause secondary hyperparathyroidism and tertiary hyperparathyroidism. Instead, we recommend that the alkaline phosphatase, either total or bone specific, be used as a biochemical marker of osteomalacia and a treatment target. Again, cautioning that phosphate salt should not be used alone. And again, with conventional therapy, monitoring for hypercalcemia and hypercalciuria is recommended. And then again, as in children, thinking about complications of treatment and how to treat. In treating tertiary hyperparathyroidism, if there's hypercalcemia, we recommend calcimimetics. If hyperparathyroidism and hypercalcemia remain uncontrolled, then parathyroidectomy is recommended. And then to treat hypercalciuria by reducing active vitamin D dose and then using hydrochlorothiazide, potassium citrate, low salt diet, and increased fluid intake. And what I also loved is there was a focus on dental recommendations, both in adult and children. And this is different than previous recommendations and previous guidelines. Again, annual dental visits, and then treat if there's active oral issues, treat with conventional therapy or furosemide to reduce the risk of dental infections and severe periodontitis. And then again, clinical and radiographic assessments evaluating spontaneous pulp infection and periodontitis. And then again, performing advanced imaging, potentially with other cone beam computed tomography, if there's recent oral manifestations and follow-up. And then implant surgery can be performed, but you need to prepare the individual's bone with medical treatment 3 to 6 months before, and should be continued through the implant and through the healing process. We also talked about pregnancy and lactation. I think suffice it to say that I will refer you to the paper for our recommendations in pregnancy and lactation, just for concern over time right now in the seminar. And then finally, again, this is a graded monitoring recommendations, again, based on the clinical practice survey. And this is what we suggest for monitoring in adults with XLH, pain assessments and clinical assessments for fractures. Again, measurement of height, weight, BMI, and blood pressure, documentation of dental infections and history, measurement of phosphorus, corrected calcium, alkaline phosphatase, eGFR, PTH, 25-hydroxyvitamin D, and spot urine, calcium and creatinine, and phosphorus and creatinine. And then every 6 to 12 months, dental checkup, clinical physical examination for skeletal deformity, osteoarthritis, and joint restriction. And presence of neurological deficit, again, a comprehensive neurologic exam, imaging, and referral as may be needed. Again, annually a renal ultrasound, and annually in the presence of bone pain, skeletal survey, or x-rays to screen for fractures and pseudofractures. And so finally, I was inspired by Leanne's, what she said she appreciated about the guidelines. What I appreciate about the guidelines are, again, they are a great roadmap for individuals and practitioners that aren't familiar with XLH. I really appreciated the breadth and the depth of expertise on this international panel. And I really appreciated the patient voice on this panel. And I appreciate the patient voice today, spurring us on to where to go next in our research and answering these important questions. I also appreciated these were widely endorsed by over 20 international professional organizations, and that we use this dual methodology of systematic reviews and clinical practice survey with a graded methodology. I also enjoyed the extensive discussions that we had about identifying, treating, and monitoring extraskeletal manifestations, and guidance of pregnancy and lactation, and appraisal of the current evidence gaps with guided future research. And with that, I will end my comments and thank the other presenters and thank the attendees and look forward to your questions.
Thank you so much, Suzanne, for guiding us through the roadmap, as you said, and navigating us through the adult world of XLH. It's now my pleasure. Thank you to all our expert speakers. I think it was a really great overview and different perspectives. We now have a few minutes for the Q&A, and we have quite a few questions in the chat. We're very happy to take your questions, so please send them over, and I will try to put in as much as possible. The first question is a very interesting one. Leanne, probably you could comment on that regarding guidelines and the applicability in low-resource countries. We're talking a lot about burosumab, we talk about intact FGF23 testing, we talk about genetic testing, knowing that a lot of patients will not have access to these diagnostic measures. Do we have in future an implementation for low-resource XLH care in the guidelines, and how much is reflected already in the guidelines?
Mm-hmm. Well, thank you so very much for the question. And I had mentioned that this was one of the issues that I was particularly passionate about, is how do we bring these guidelines to low-income countries, and what do we need to nuance in order to do that? What I would say with respect to the diagnosis, as I mentioned, one does not need an FGF23 level in order to make the diagnosis. The diagnosis can be suspected on the basis of the biochemistry. I'm not sure if everyone has available to them a 125 dihydroxyvitamin D, but that is considered somewhat of a surrogate for FGF23, so that can be helpful in that situation. I think that clinically we can triangulate on whether we think there's an FGF23 mediated hypophosphatemia or an intrinsic renal defect. If for some reason you make a mistake and you don't actually have XLH and you go forward and you treat, I think that as long as you're not treating a condition that's characterized by ectopic calcifications, then the patient would probably benefit from the conventional therapy if that's what you have access to. So I think when you're not available to you having genetic testing, for example, make sure you're not making things worse with conventional therapy by giving that therapy to someone with calcifications. And so you can go looking for those on x-rays to reassure yourself in that way. So I think there are some ways to think about this. And the question itself, I think, teaches us as a panel that we need to be thinking about perhaps a compendium that specifically addresses the issues related to low and middle income countries, and very much appreciate the question.
Thank you so much for summarizing that and also showing that most differential diagnostics can be done with quite low cost tests. Mm-hmm. And this is the important message, I think. Thank you so much. Another excellent question, Suzanne, probably going to you regarding the elderly with XLH. And we have a very specific set of symptoms there. One symptom which was mentioned here is the joint pain and stiffness. And I would like to add also joint replacement, which is sometimes very tricky regarding a strong deformity. How is your experience regarding considering surgery and referring to surgery, especially in the elderly population with XLH?
Well, thank you for that question. It's an important question. You know, I think one thing that didn't come out, I think, in some of our systematic reviews and our recommendations is that in the Insonia, the phase 3 clinical trial of burosumab, there was an improvement in stiffness in adults with XLH. And I see this in my patients who I treat with burosumab, who are adults with XLH, that their stiffness improves. It doesn't completely go away, but it improves dramatically. So I think that when we're thinking about symptoms, that if there's no fractures or pseudo fractures that are present, if there's significant stiffness, sometimes people can improve on burosumab. As far as joint replacement goes, if a joint replacement is indicated, then I would definitely prepare the patient before joint replacement with either conventional therapy or burosumab to improve the quality of the bone, to improve the osteomalacia so that healing can ensue. And so before orthopedic surgeries, I would definitely prepare the patient and through the orthopedic surgery and through the healing process. And I didn't know if anybody else wanted to add to that, add to that as well.
Tom, would you have a comment on that? Having decades of experience with XLH patients.
Yeah, I think the clear and hard message is to prepare people for elective surgeries, because the hardware just doesn't anchor. The failures of the surgeries are high. My sense is that's kind of an absolute, an absolute recommendation. I'm not sure you could grade it, but it's, pretty frequent, been pretty frequently observed historically. All of these are extremely difficult situations, particularly when you get into the spinal stenosis world, where the surgeries are not simple and one has to look at anticipated function after the surgery. And it gets very hard, I think, to make broad and sweeping recommendations about some of the types of issues that these patients are going to encounter.
Thanks for that. Thanks for that. I have to look at the time. Probably a last question, and very important for me. One of the biggest changes the last decade, besides of burosumab, is that we have the strong patient voice included in research and also in clinical approaches. So my special thanks to Tenna. And Tenna, I would really like to ask you, from the patient's voice, from the family's voice of people with XLH, what particular topics do you see kind of under-addressed? We just heard from Suzanne stiffness. I think stiffness, we all see that patients improve under burosumab. We still don't know what exactly is that stiffness. We don't understand it medically. There's so many white spots on the map. What would you see under-addressed, and where should we direct to? This might be of course, a very personal view.
Yeah, so from a personal view, at least, I would say that stiffness is definitely on top of my list. But again, I think also as a mother to a daughter who does not know if she has to go over to conventional treatment, for me, that is definitely a huge focus as well. So what happens to bones that have been growing with the burosumab treatment, and then coming off that and then going over to conventional treatment? What does that look like? Because I've kind of grown up with the point that so the bone is at least built differently to kind of better accommodate what happens later in life, and then what happens now that we have normal bones, and then we all of a sudden go back to conventional treatment. So I think those are some of the major focuses right now. So stiffness is as for me as an adult. And Adalbert, you said before, elderly with replacements. I'm I'm in my early 40s, and I've had 3 already. Well, 5 actually, if you count my jaws. Yeah, stiffness and also knowing the impact later in life on changing treatment plans.
Thank you. We definitely put that on our to-do list. And I think those are very, very important goals to have that also implemented in our future actions. Can I add a quick thing? Sure, of course.
The thoughts about how long you continue on burosumab. So some guidelines say 20 to 25 years old, and that is something that I would really love to explore further and see if there's a more clear recommendation on how long to continue children on burosumab.
Absolutely, which will also be kind of an economic issue that's mostly driving this, because in the data we see the advantages, of course, of normalizing phosphate metabolism. Thank you for including that. I'm very sure we hear a lot about those topics. I think we could still talk for hours, but our time is running out. on behalf of Martine and Federico, I really want to thank Federico from IFMRS, Kyowa Kirin as a sponsor, and of course our 4 expert speakers for these stunning talks, and of course to our audience to be with us. And I very much hope to see you during the next meetings, during the next XLH events in the rare bone disorder world. Thank you so much.
Thank you. Thank you.
Thanks, a pleasure to participate.
Thank you very much.
Thanks for the opportunity.